Have you ever wondered if medications for obesity would be right for you? How would you choose one? How would you know if these are covered by your insurance? We'll break all of this down step by step in this podcast, and we'll give you the guide that we give our patients on how to get the best deal you can on these medications. I hope you enjoy this episode. All right, welcome to the podcast again, Dr. Doug Podcast. Tonight I have Casey Hilde. He is a PharmD pharmacist and actually works with me at the Arizona Obesity Organization on our nonprofit organization that we are part of.
I'm Casey Hilde. I'm the Director of Clinical Pharmacy for Optimum Primary Care. These are my own thoughts and opinions on this topic, not the opinions of the organization as a whole.
Thanks for joining me, Casey.
Yeah, thank you for having me. I'm excited to be here, and I joined the AOO to ensure that my patients had access to these new types of medications, and so I'm excited to discuss coverage further.
Yeah, we're actually really excited about some initiatives that are going on that Casey is working with us on, and we can talk about those a little bit later. So Casey really is my subject matter expert in this area. So I wanted to bring him on and talk medications. So he is adjunct professor, correct me if any of this is wrong, and preceptor for the pharmacy students at the University of Arizona College of Pharmacy. You have a doctorate of pharmacy from the University of Arizona, U of A. You've been practicing in Arizona since 2018. Were you practicing before, or was that when you started your career?
That's when I first finished my schooling, and then I started at a small private practice, and then that role has expanded, and now we were bought out by a larger corporation, and so now I oversee the integration of clinical pharmacists and pharmacy technicians into internal medicine and pediatric, as well as specialty clinics across both Arizona and New Mexico. So we have about 75 clinics between Arizona and New Mexico right now.
Yeah, that's pretty cool. The unique thing about your position really is that you're in a clinical position. So you're helping people with actual medical care and making treatment decisions as opposed to just managing the medication like the fills and the dispensing and stuff like that.
Yeah, very, very different. I'm in a collaborative practice agreement with the medical group and the providers at the own clinics there, and so we see patients directly in clinic, myself and the other clinical pharmacists, for a wide variety of disease states, but probably 50 to 75% of those patients are diabetic or obese, or a combination of both of those things. And so this is a topic that's really near and dear to me, and the reason that I joined the AOO in the first place.
Yeah, thanks. So this may sound boring to some, hopefully not, but in case it does, medication treatment for obesity is actually one of the most exciting areas of medical science right now. I mean, it's just exploding with opportunities and new discoveries and new ways to use existing medications and using the newer medications, and all sorts of questions around this, like who should get treated? Who knows about treatment even? So many people don't even know that medicine treatment is an option. Once you make that decision, how do they get coverage for the medications through their insurance? So that's a huge hurdle that we go through with our patients a lot. And then there used to be a problem with supply. So as the popularity grew, the supply was not enough, and so the shelves are just empty with medications, and people were running out of medications. They couldn't get their medications. So that improved earlier this year, but through that cycle came the compounding scene, and we're going to talk about that a little bit. It's really not the focus of tonight, but we'll talk about that a little bit too. And then one of the most exciting things here is the emergence of new disease treatment options. So we have a couple of these medications that have now been cleared through the FDA for specific disease states besides just obesity. So we
Yeah,
have,
and my hope for this and these disease state additions we're going to see an increase in coverage, hopefully, for these medications. I think some of them people may know about, but I think that we have several that came out this last year, and hopefully that will be an avenue for people to obtain coverage. As of right now, it can be difficult for plans to have coverage for weight loss, but I think that that's ever increasing, and that's part of the AO's mission, is to ensure that patients have access to these medications.
yeah. So as these new opportunities come up, it opens the door quite a bit for people who may not have had coverage before, but now with this new opportunity, they might have coverage. We can talk about that. So there's a number of situations that offer opportunities here. And then the age-old debate about who should get medication treatment. We're not going to dwell on that too much, but it's actually a huge decision point for us in our medical practice, and maybe we could touch on that just a little bit as we go. It's interesting how each of the medications has different characteristics, and they actually help in other ways as well, besides just weight loss. And so, do you want to talk a little bit about some of those other side benefits, or even some cautions that we need to be aware of when we are looking at each one of those?
So I'll kind of talk about the big groups of medications first. We do have orlistat, which is also available actually over the counter. I don't use this product quite as frequently. It does have a little bit of a negative reaction in some patients. It does impair your fat absorption, and that's part of how patients lose weight. It can be a wonderful tool, but for some patients, especially if they overeat fatty foods, it can cause kind of some significant GI upset and some fatty diarrhea. And so that's kind of the main issue with that one. Most patients tend to be fairly okay candidates for that one. It tends to be fairly well tolerated, except for those potential gastrointestinal side effects. Phentermine on here, this is really the main stimulant that's still in use currently. As a singular product, it's something that we're very cautious with in general. Stimulants, especially at high dosages, we know increase heart rate and blood pressure. And so for patients with a significant cardiovascular history, for patients who've had a previous heart attack or stroke, we want to be really cautious with the stimulants in general. We do know that these drugs work well, but we just need to be mindful of those potential cardiac side effects.
And these are ones that, Casey, these are ones that we've used for some people who have low energy. Sometimes it helps a little bit there. And for people who measure low on their metabolism tests, there's some studies out there that show that phentermine might be a good choice for people in that situation.
Yeah, absolutely. I think that, and the other important things about phentermine are we want to make sure that if you do get prescribed this product, just to be mindful and take it in the morning. That burst of energy is wonderful in the morning, but if you take this product in the evening, it will most certainly keep you up at night. So these stimulants are typically given in the morning, but I've had very good results with them. They're also products that we don't typically use very long term. We give these products kind of in bursts just to ensure safety because of that potential increase in blood pressure and heart rate. But I think that there is absolutely a place for these types of medications, and they're still being used, and they are by far the most reasonable in terms of cost for most individuals, and so that's a big part of the reason why I think they're still very regularly used.
Casey, not to counter you, but we actually use it long term in a lot of patients successfully, even though it's technically off-label to do that. We just talk about the risk involved and some cautions, so we'll do that carefully in some people.
Yeah, I think that's good. As long as you're being monitored by your healthcare provider, I think that's perfectly reasonable. I use these products frequently, and I absolutely understand the need for them. And I think that there really is a specific subset of patients that this really is potentially the best option for them. More recently, we got an approval for phentermine and topiramate, extended release topiramate, and I think that that product is likely probably a little bit safer to use long term. It allows us to use lower dosages of the stimulant, which is nice. And then the topiramate likely helps with cravings. And so I've had very good success with this. And both Qsymia, which is the phentermine and topiramate, and the medication next to it, naltrexone and bupropion, which is known as Contrave. Both of those medications do have fairly generous programs, which for most people can make it fairly reasonably priced. And so I do use those fairly frequently as well. But if patients have no insurance coverage and finances are an issue, or just you're needing a little adjunct, I think that a phentermine addition, even on top of some of these other products, may potentially be a reasonable addition if patients are on medications like semaglutide or tirzepatide and need a little boost. I do frequently add a medication like phentermine on.
The pricing for those, Qsymia is about, Qsymia and Contrave both have a $99 deal through their manufacturer pharmacy.
Yep, and I think that that's a really reasonable deal. As of right now, it has been fairly difficult for patients without coverage to get the newest agents. And so we do know that the newest agents, so you can see over here on this table towards the right, semaglutide and tirzepatide, those are our once weekly injections. They tend to be fairly effective. They tend to work well in patients who have concurrent type 2 diabetes, and so that's why we see semaglutide being both Ozempic for diabetes and Wegovy for the treatment of obesity, and then tirzepatide we see as Mounjaro for diabetes, and we see it as Mounjaro for diabetes and Zepbound for weight loss. And so we see these medications. I think that these are kind of the big medications that most patients know about right now. There is that benefit in diabetes. We know that there's likely a benefit in semaglutide, tirzepatide, and liraglutide, which is that Saxenda product. We see that benefit in lowering blood pressure as well in clinical trials, which is a very good thing. Currently, we know that there's a demonstrated benefit in liraglutide and semaglutide in patients with ASCVD, which means patients with that cardiac history, patients who've had a heart attack or stroke. We know that there's an observed benefit in these patients with these types of conditions. And so patients who've had a heart attack or stroke, we know that these are good medications to put them on, and they're less likely to have recurrency of that cardiovascular condition.
That one's really interesting. It looks like the medical studies show after getting the standard of care treatment, so after a heart attack, so taking the cholesterol medication, taking your baby aspirin, blood pressure control, and everything else, this when adding Wegovy to their treatment, they get an additional 20% reduction in their heart attack and stroke recurrence risk. So that's actually huge to me. I mean, doing as well as we can do before, this adds another 20%. That's a pretty big deal.
I absolutely think so. And in speaking earlier about some of those new indications, or one of those other indications, Wegovy does have that approval for those patients with ASCVD because of that large benefit that was shown in those trials. And so I think in those patient populations, it may be added at some point as a general standard of care, just because we see that very large decrease in cardiovascular risk for patients on these medications.
Yeah, the recurrence risk already is pretty high. People have multiple heart attacks, they have multiple strokes, and it's hard to prevent that sometimes. So yeah, that would be awesome.
Some of the new indications that we see for these classes of drugs, we can get into a little bit on this slide here. But recently we saw an approval for MASH. This used to be called fatty liver. On here it says MAFLD. But some of these drugs are likely going to be gaining approval for this indication, and actually tirzepatide just recently did gain approval for the treatment of MASH. And so those patients, we think we may see another avenue for coverage for these patients. There aren't many treatments. There's really only one other treatment that's available for MASH currently. And so this is one of the first treatments that's become available for MASH in this patient population. And so I think that that's going to be a big deal, and hopefully an avenue for patients to obtain coverage as well.
Wegovy specifically for that one.
Oops, I'm sorry. Sleep apnea is sleep apnea is tirzepatide.
So fatty liver causing liver damage, which MASH is a technical acronym for that term. That just came out about a month ago, right? For
Yeah,
the
so
approval for that?
yep, the approval for MASH occurred about a month ago. For patients on Wegovy, first on semaglutide, and only for patients with moderate to severe MASH. And so I think that that's an important indication. They do staging on this, and so not necessarily every candidate with MASH is a patient, but those with moderate to severe MASH may potentially be a candidate. That's obviously a discussion for patients to have with their provider. But I have been able to get some patients on Wegovy who don't have obesity coverage, who do have MASH. I have been able to get them on the medication, which I think is a very big deal.
Yeah, a lot of my patients who have that are pretty scared about it because they read about how it can develop into liver failure, cirrhosis, and it's a pretty serious deal. So this is a serious medical condition that really needs something like this for treatment. And there's already some other medications for it, but this adds to the arsenal as well. This is
Yeah,
really the only one that leads to weight loss in relation to it too.
Yeah, I think we see this nice plethora of benefits with these GLP-1s or the GLP-GIPs. We see benefits in multiple disease states, and I think that likely other disease states will continue to be added on in the future here. I think that this class of drugs is kind of touted as miracle drugs, and I can speak from firsthand experience in seeing my patients lose weight and seeing them obtain diabetes control and seeing them take control of their diabetic kidney disease. We see benefits on multiple accounts on these types of drugs. So I think that patients are curious about these drugs. I think I see many patients every week who come in just to basically ask me about these medications. And I think not all providers may have this information. So I think this podcast in general is a good resource for providers, but also a good resource for patients in having those discussions with their providers and kind of being primed and ready for what type of medication they may like to be put on or what medication they may be a potential candidate for as they go in to discuss with their providers.
Yeah, really. You touched on the sleep apnea with Zepbound, and that's been out for a little while. We've been using that as well, and we're trying to use that in conjunction with using CPAP treatment as well as the weight loss. But that as soon as you get into that pathway, you can decide what kind of treatment you want to go through based on with your obesity specialist and with your sleep doctor together.
Yeah, absolutely. Yeah, and tirzepatide, which is Zepbound, fairly recently got that approval for sleep apnea, for moderate to severe sleep apnea. And so same thing, not necessarily everybody is a candidate, but I think it is important to note that it did gain that approval, and we have been able to get some patients coverage under that indication, which is very good, and that this is typically used in addition to CPAP. I think that that's an important note. But we know that these medications and the weight loss help with sleep apnea. And so I think that it's kind of an exciting new thing and a good option for patients with moderate to severe sleep apnea.
Yeah. So, Casey, I was thinking about the diabetes prevention with these medications. And I was kind of doing a little thought experiment, kind of pacing this out and seeing if we were to really prevent a lot of diabetes cases, what that would look like for our society. So I also want to say, I totally support dietary changes and exercise as much as possible. I've been preaching that to my patients for years. And so I still want people to know that we're not just talking about medications only without any other treatment. But what if we could prevent 90 to 95% of diabetes cases? I mean, that would be crazy. What would that look like for us? We have millions of diabetes cases in the world right now. That would be almost eradicating diabetes. Think about that.
Yeah, I think it's a really interesting concept, and I think it's something that we may kind of see. We've kind of already started to see a little bit of this kind of happening as these drugs came out and patients have trialed these drugs. It's going to be interesting to see kind of what the next 5 to 10 years holds here in terms of coverage for these medications and the number of people on these medications. I think we see something kind of in these industrialized countries where, especially in the United States, many individuals are overweight or obese, and that number has been increasing and increasing over the years. And kind of for the first time in a long time, we're seeing that number stall, and some studies even show decreasing, and that's likely due to many of these patients trialing medications like this. And so I think that we may see, in general, less people who are overweight and obese in the future if they have access to these types of medications, and we'll see less obesity-related illnesses such as diabetes and hypertension and hyperlipidemia. We'll see those types of things being less commonly diagnosed because of medications like these coming to the marketplace.
Yeah, really true. So let's show another visual. This is one that I show to my patients, comparing the efficacy of different treatment options. So this is a slide that I put together from as many studies as I could pull. So I have the sources back in my files, but when you compare different treatment options to each other and then to bariatric surgery, looking at what percentage of people in these medical studies achieve a certain weight loss goal or weight loss result, it tends to give you some perspective on which one might be right for you, which one may lead to a certain outcome. And so I talk about this with our patients. These are all averages. Definitely there's outliers, and there's people on both sides of the spectrum. But when you talk about behavioral modification, which is diet, exercise, in the medical studies, you see that about 50% of people in this little first bar can reach about 5% and maybe even less of weight loss. Fewer than that can reach the higher weight loss results. So about 35 to 40% can reach the 5 to 10% weight loss. And then fewer can reach the 10 to 15 and fewer reach the 20. So this there's definitely people who can jump on a diet program, hit the exercise routine, and really make it. But then on average, there's about 50% of people who can get just into the 5% weight loss. And that's been disappointing to me and surprising too when I first learned about this. Then you add or look at other medication options. The next one on the chart is phentermine, and its average weight loss is maybe about 8% or so, about where people can reach as a weight loss result. And then Contrave, the full average is about 8%, but there's this subset of people who tend to do well with craving control. And these patients end up getting about 12 to 13% weight loss, which is actually really cool that they can get to a higher level. And then Qsymia that you talked about earlier, that's about the same range as the Contrave, 12 to 13%. And then you get to the Wegovy and Zepbound medication. So Wegovy's about 15% and Zepbound's between 20 and 22%. So
I agree.
yeah, it's cool to have medical studies like this that show us average results, but everybody really responds differently. So where you're going to fall on that spectrum, you really don't know until you jump in and start doing it.
I agree, and I think there's a time and a place for each of these interventions. I think that many of the patients who come to see me for the first time, they may have tried some behavioral modification in the past and may have not been as successful as they would have liked and are then seeking pharmacologic intervention. I think many patients are maybe a little hesitant to jump to surgery. I'm a big proponent of bariatric surgery. I think that there absolutely is good outcomes in bariatric surgery, and as you can see, We still don't have something that's quite as effective as bariatric surgery, but you can really see with Zepbound and Wegovy that they are getting fairly close, and I think that that's a very big deal, that the weight loss for some of these newer medications is approaching bariatric surgery, and with some of the newer drugs that will come out in the future, they're going to be very, very close to these bariatric surgery numbers. And so I think that this is a very big deal, and if patients can get started on some of these types of medications, they may not need surgical intervention, which I think is a wonderful thing as well.
Yeah. There's a number of different situations where the medicines might be really helpful. So we've worked with a lot of people who are actually doing an exercise program, doing as well as they can with their diet, sometimes not even eating enough, and they're stuck at a weight. Some of these people have already lost 5 to 10% of their body weight and maybe even more. So good job to them. I mean, doing great work, but still stuck way higher than they want to be, and still with, things like liver disease, or even at risk for heart attack, or having had a heart attack or something like that. So once you get some of those diseases, it's actually really helpful to consider a medication and continue your diet and exercise. But that's a great time to add something that would really lower your risk for future diseases.
Yeah, I 100% agree, and I don't think necessarily that medication is always the right way out necessarily, and I think that no matter what, these medications need to be used with a diet and exercise regimen. I think that that's a very important clinical piece to all of this. It's important to make those lifestyle changes, and they do need to be lifestyle changes. I'm not a big fan of fad diets or that sort of thing. These need to be lifestyle changes to really make that difference last long term. These medications are wonderful and make a big difference, and the newer medications even more so. But without those lifestyle interventions, patients will likely gain the weight back, especially if they are to stop the medication at some point in time.
Yeah.
So I wanted to provide a little information on some of the other indications that maybe have recently been approved for Wegovy, which is that semaglutide on this slide here. I think we know that this product is approved for diabetes as Ozempic, and I think we are aware of the blood pressure lowering effect of this class of drugs, and the cardiovascular benefit that we see of Wegovy as previously discussed. Recently, very recently, within the last month or so here, it did get an indication for MASH, which is metabolic dysfunction-associated steatohepatitis, which falls into that fatty liver category. And there aren't a lot of medications that are currently out for this, and we see a pretty sharp benefit in terms of the clinical benefit for patients with MASH, especially moderate to severe MASH. And so recently, Wegovy did get an approval for MASH, and I think that may open up an avenue for coverage for patients with this disease state.
Yeah, that's really exciting to have something on this side of the treatment spectrum, meaning like on the obesity treatment side for MASH and reducing the chance of liver damage. It's going to be huge. We're really excited about that.
Yeah, and I know patients are especially when they get that new diagnosis, I think that there's a tremendous amount of fear that patients have, and it's nice to have another tool in the clinical toolbox to potentially treat these patients with. I think it's going to be a very big deal, and there's so much overlap between the disease state of obesity and the disease state of fatty liver that I think that there's going to be a tremendous amount of overlap in these patients, and hopefully will open up an avenue for coverage for these patients.
Yeah.
Perfect. I think the only other medication we may have missed in our topic here is the medication in the very center here, this naltrexone and bupropion ER. This is known as Contrave. This is one that I use frequently, and they do have a nice cost savings program. For most patients, they are able to get it for that $99 out of pocket. There is a benefit in weight management. We do need to be a little bit cautious with heart rate and blood pressure. The bupropion component we do know can increase blood pressure and heart rate, so we do just have to be cognizant of that to a lesser degree, almost certainly than phentermine, but something to be mindful of. And then because bupropion is used as a medication to treat depression, obviously if you're on an antidepressive agent, we want to make sure that that's being monitored, and any changes in mood that you discuss with your provider. And as it does increase blood pressure and heart rate, and as bupropion in general, in some individuals can exacerbate anxiety a little bit, we're just cautious with the bupropion component. The other component is naltrexone, which we need to be very cautious with as well. It's an opioid antagonist, and so for patients who are on opioids, this in general isn't a good option for these patients. And if they are to go to the hospital or something like that, it's very important that they let the hospital staff know that they are on bupropion and naltrexone, because they are on an agent that antagonizes opiates if they're trying to give you pain control.
Yeah, like if you need morphine or something like that, the effect of that would be much less if you have that naltrexone on board.
Yeah, 100%, I agree.
So if anyone's out there wondering if medications would be right for them, a couple ways to think about it. Have you tried to achieve your goals with as strict a diet as you can and as good an exercise program as you can? If you still haven't lost as much weight as you want to and need to, there may be health benefits to you for trying a medication in addition. And the other place really is when you have a medical condition that's related to obesity, like the ones we've talked about already, the heart attack, the stroke, sleep apnea, the fatty liver disease with inflammation, which is the MASH. Those are areas where it's really hard just with diet and exercise to get enough risk reduction, to get enough treatment. So those are areas that I'm encouraging people really to think about medications, because now you have an actual disease process going on, and we'd want you to have the best option that you can to reduce that risk.
Yeah, I very much agree. I think that for so long, unfortunately, we've kind of unfortunately pushed the blame on the patient in terms of obesity, and I think that there's some societal burden of this disease state. And I think, unfortunately, for so long we've said, oh, you need to diet, you need to exercise, and kind of pushed that onto the patients. And I think now we know that obesity is a disease state in itself, and needs to be treated as such. And especially if you have these other concurrent disease states, if you have cardiovascular disease, if you have sleep apnea, we don't want those conditions to worsen. And so it's important that to potentially look at treatment in these types of patients.
Yeah, there's so many people who have tried diet and exercise and still do it, and they're really stuck. So we want people to know that there's treatment options out there in addition. Lots of people are feeling frustrated, they're mad, they're even hopeless. What's the next step? They're trying everything they can do. They can't think of anything else to do. So you don't have to wait till that point to consider medications, but certainly, at least by that point, consider medications as an option that can help you.
I 100% agree. I think that these medications are adjuncts to diet and exercise. And I do think that some patients may be better candidates for surgery. And then also, I do have many patients who've had bariatric surgery, and over time they may have gained a little bit of that weight back. And we've been able to put them on some of these other medications, and it kind of gives you, especially the newer weekly medications, it kind of gives you that feeling for when you had bariatric surgery, that kind of intense feeling of fullness that unfortunately a lot of people don't feel. And these medications, I think for the first time in a long time, it allows patients to eat till they're full, and kind of not push past that feeling. And we know that there is a little bit of a negative feedback with these medications, and potential nausea or potential gastric reflux on some of these newer medications. But I think that that negative feedback is part of what makes these medications beneficial. I think it's a good thing in a certain way, because if you overeat, it does make you feel it. And so it kind of puts you into that mindset of, I'm going to eat appropriate portions, and it does help with those cravings, and it does increase that satiety level, that feeling of fullness longer term, which I think so many people want that and need that feeling. And I think that this is really the first type of drugs that have come out that give you that feeling of satiety, which I think is truly wonderful.
Yeah, yeah. I mean, if you think about the medication options that are out there now, some of them, these newer injection medications are actually targeting some of the defects that people have with obesity. And so there are now disease-specific medications and not just appetite suppressants too. So the mechanisms are getting more complex, but more elegant too. You know, they're targeting specific receptors, specific hormone levels, and not having as many side effects as what the older medications did. So, you know, the medications have really gotten notoriety, I think, for good reason. I mean, they're working so much better than what we used to have. So it's just exciting to be able to offer people treatment options now.
I absolutely agree, and I think that it really expands the patient base that you can offer those medications. And I think previously, and unfortunately, many patients who are obese may have that cardiovascular history where they may not necessarily be a stimulant candidate, but now we can offer them medications that provide benefit to their heart. And so this is kind of I think providers can feel much more confident kind of safely writing for these medications. I think there's really very few contraindications to the new classes of drugs, these GLPs and GLP-GIPs. Really, it's mostly gastric. We are concerned about patients with pancreatitis histories. We're concerned about patients with gastroparesis, with that slow GI tract diagnoses, and we're concerned about patients with a family history of medullary thyroid cancer, which was really seen mostly in the clinical trials. That increase in medullary thyroid cancer, that I think is mostly due to we've seen that in the clinical trials, and it really hasn't panned out that way in terms of the GLP-1s, but still is a warning, and I still inquire with my patients if they do have any contraindications. But contraindications are few and far between, and in general, especially with the newer agents, I feel very safe writing these medications for my patients.
Yeah, it's really cool now with these new disease states. We know cardiologists who are recommending Wegovy because of that heart attack risk reduction in people who have had heart attacks before. We know sleep specialists who are out there recommending Zepbound for treatment of sleep apnea, in addition to their CPAP treatment as well. We also know hepatologists, liver specialists who are out there recommending Wegovy, and actually have been doing it even before these results came out because we had seen these benefits for people with fatty liver and liver damage. So, it's getting to a point where we are getting more technical in this area, and there's a lot more treatment options.
I think it's a really exciting time to be in the obesity medicine space because for the first time in a long time, we really have a lot of tools in our clinical toolbox to be able to offer to patients.
Yeah. So for anybody who thinks that they might be interested in discussing medications with their doctor, or feel like they even want to consider medications, your primary doctor may very well have enough preparation to know what to tell you. They're all going to know what these are. Some of them are prepared to prescribe them. Some aren't prescribing them. But at least start there. Your primary doctor is doing all of your medical care for general stuff, and that's a good place to start. If your primary doctor doesn't prescribe these, or you need to go to a specialist, there's a lot of obesity specialists in the U.S. And we'll put up a link here to the Obesity Medicine Association, where they have a specialist search, and you can search for specialists that are registered on that site. I know there's also a registered site on the Obesity Action Coalition website as well, and there might be others out there too. So if you need to, go ahead and do your own search. Find an obesity specialist if you need to, and that may really be a good option for you to have an in-depth discussion about what the pros and cons are of treatment.
And I do think a lot of this feeds into the cost and coverage discussion on these classes of drugs. And I think that many primary care providers are really aware of these types of medications, but they may not be writing for them regularly just because of concerns with cost and coverage for patients and prior authorizations and kind of navigating the health insurance space, and I think that that can be very difficult. And so I think that's an important thing that we talk to a little bit as well, is just insurance coverage patterns and what that means.
Yeah, so we wanted to talk about cost and coverage. That's a huge issue. So what would happen if you decided you wanted to get treatment? Maybe your doctor suggested it and already prescribed it. What are the chances of you getting coverage from your insurance? Once you get coverage, how much is it going to cost you? How much are your copays and deductibles going to be? And what if your insurance plan doesn't have coverage for this? What do you do then? So let's talk about a few coverage patterns that we know about, Casey, and just pull up some options for people so they can have an idea of what the options are here.
Yeah, I think, and the unfortunate answer is always it depends. But in this specific case, for
It's very technical, isn't it?
absolutely. In
Yeah.
this case, for employer insurance plans, employers do have to opt in, and not all employers have opted into coverage. If your employer hasn't opted into coverage, I do think that that's a reasonable discussion to have with the HR team at the specific companies that you're working at, to kind of see if that would be an option or if that's going to be an option at some point in the future. But many commercial plans, many employee insurance plans do have coverage. Unfortunately, and the population that I primarily work with is Medicare and Medicaid. And Medicare is pretty tough. Obesity itself is a disease state where coverage is generally excluded, unless they have another FDA-approved indication. So for these patients, if they have an ASCVD diagnosis, or if they've had that past heart attack or stroke, if these patients have moderate to severe sleep apnea, and then more recently, and on a few plans, we're seeing MASH coverage, but that's just kind of starting. But for those Medicare plans, potentially, if you have one of those other covered indications, in addition to obesity, they may cover these medications. Medicaid is even tougher. Right now, these drugs are just general exclusions. Doug, would you like to talk a little bit about what the AOO is doing to try and obtain coverage potentially for these patients and voice our support?
Yeah, so over the past maybe 9, 10 months, there was a bill taken to the Senate by one of the Arizona senators, and that was really meant to do a feasibility study of whether or not medications would be coverable in Arizona. You know, there's 13 other states right now who have Medicaid plans that are covering these medications. So obviously not all of them, but at least some of them have thought that it's worthwhile to do. So this went through the Senate and the House, and I got an opportunity to testify on those. Those are on the AOO Facebook and Instagram page. And the bill passed, signed into law. So now it's called SB1711. Now the committee is going to convene, and I'll be on that committee, and we'll be talking about whether or not it's feasible to provide coverage. So this is really now a population issue. You know, we have to think about philosophical questions like, should we be offering this medication as a treatment option, or is it a crutch that we shouldn't get into and get on a slippery slope, you know, running down this hill of everybody being on one of these medications? So we have that philosophical discussion, and then really there's going to be economics involved. What's the cost? What's the benefit? And, you know, we see in our patients a huge benefit. I mean, less heart attacks and strokes. A heart attack costs hundreds of thousands of dollars, and liver failure, cirrhosis, liver transplants in the future, those are huge expenses. So if we could prevent those, and we talked about preventing diabetes. I mean, the cost of diabetes is astronomical. If we could do that in a more cost-effective way, we'd have to study this, bring some numbers together. I don't have the numbers, and we're working on that this fall right now. So I'm hoping that if we bring enough data to the table, we'll be able to show some real information that shows that obesity really is worth treating.
Yeah, I think we're on the precipice here of something really, really big and exciting. And my hope, obviously, is that we can find a cost-effective manner to be able to treat these patients and to ensure that everybody has access to these medications and evidence-based medicine in general is the hope. And so I continue to voice my support for making sure we do what's best for our patients.
Yeah. When my patients get the news that their medication isn't covered, some of them are just heartbroken, and you know, I can't, I don't have any consolation to provide to them, except for my hope that in the near future, I think we'll see some engagement with policies and legislation with even Medicare treatment that allows us to treat these complications of obesity in a more aggressive and targeted way. And I'd really like to get to a point where we could treat obesity before these diseases happen. And that's a running joke in my patient population as well. So you can imagine, they're like, so Medicare wants me to have the heart attack before they'll offer treatment? You know, the impression is really interesting. So I'm hoping that we can get there to where we can actually provide real treatment for a real disease, prevent tons of downstream effects and diseases by treating this early.
Yeah, I think for right now, many of these, the coverage that we're seeing is primarily for secondary prevention. So after that event occurs is typically when we're seeing it. So you've been diagnosed with sleep apnea, or you've had a heart attack or stroke, and that's more where we're seeing coverage currently. Potentially in the future, we may be able to look at primary prevention and preventing these things from happening in the first place. And I think we're kind of on that precipice right now of those next steps and what's going to happen. So I'm excited and apprehensive to see what happens the next few years.
My patients talk about this primary prevention, meaning preventing disease before it happens, as if it's so logical. You know, when they say, so they want me to have the heart attack and stroke before they'll provide treatment, and then they're like, why don't they want to prevent this? Why does my insurance company not care about providing coverage for this when the prevention of these diseases is huge? So we need more medical data, because as soon as we bring medical data showing the amount of heart attacks and strokes that this can prevent 20, 30 years in the future, we'll really have the ammo, so to speak, that we need to show that this really is a viable treatment option.
And I think that's exactly what's happening, and I think that they're going to continue to add more disease states, and we're going to continue to understand why these medications may be beneficial. And I think as we gather that data, and really the essential part of medicine is ensuring that we have these high-quality outcomes, especially when insurance companies are looking at paying for something that is potentially fairly costly. I think we want to make sure that we have that data to back it up, and I think that's where we're headed. So I do think that's a good sign.
Yeah, yeah. So for anybody interested in whether or not their medications could get covered by insurance, we actually both had sheets that we were using with our patients and kind of came together and revised this. So we have a tip sheet here on how to talk to your insurance company about checking coverage. So we'll make the link available here in the description down below with the podcast, and give you a step-by-step guide on what questions to ask your insurance company when you call them. And just remember, some of these reps don't give accurate answers. They may not know the whole truth regarding coverage, so you just have to be discriminating here as you're making these phone calls, and you can check coverage before you go in to see your doctor.
And I think that's important, and I think your doctor will be more likely to potentially prescribe these types of medications if it's not something that they normally do, especially if you're fairly certain that you have coverage going into it. it saves a great deal of paperwork on their end and searching on their end if patients are able to go in with a little information on their own. I think that being an advocate for yourself is very important, and it's something that I always want my patients to do. And I think that them taking a personal responsibility and kind of coming in with that information makes it a lot easier for their provider, who may be extremely busy and may have many patients that they have to see every day, and to do this additional paperwork and then get a denial to just saying that your insurance is excluded coverage altogether it's brutal. So I love when my patients check beforehand, and I generally have them try and check beforehand, and it saves me a great deal of heartache down the road.
Yeah, yeah. The other benefit to checking your coverage before you go in, if you know you have coverage and your doctor has a sample in the fridge that they can provide to you, you can possibly start that right away, and you won't have the chance of getting it taken away or not being able to continue it later. Yeah, and then if you know that your coverage is excluded, then really you could spend your efforts on other ways and try other medications without having to go through that denial process.
Yeah, I think starting early and effective treatment is extremely beneficial, and I think there are some ways kind of that may potentially be beneficial. There are copay cards for patients with commercial insurance, which do help a great deal. If you have no coverage, we were kind of talking, virtually all of these medications do have plans where you could potentially obtain these medications for a reduced cash price, with phentermine and topiramate having that $99 copay program, the naltrexone and bupropion, the contrary, of having that same type of program. And then Wegovy and Zepbound both having direct patient access programs as well for these meds, which I think are for Wegovy, I believe it's $499 a month currently, and then for Zepbound, I believe the starting dose is $349 a month, and then all the higher dosages are $499 a month. So they can be a little bit expensive, and I think that is part of why we've seen so many of these compounding pharmacies come about, which I think is another issue and potentially a topic for another time. But I think that the higher tier costs on these medications are kind of why we saw that compounding happen in the first place.
Yeah. Well, you hinted that the compounding was an issue, and maybe let's just make a comment here, even though we're not going to talk about it in depth. But you, as a pharmacist, I mean, you support compounding in general, and even have some support for compounding these substances. But I have a position, and our Obesity Medicine Association has a position too, that we have concerns about the safety, the consistency, the sourcing of these medications. So, there's definitely disagreement, and that would be a whole podcast in and of itself to address that issue. But people should know at least that they have come out and doing compounding, and then the FDA had opened the door because of drug shortages, and has since closed the door for compounding with official FDA rulings.
Yeah, I think that initially these medications, there was a large-scale shortage of these medications, and so the FDA opened this up. Now compounding pharmacies are often including other medications with these medications, and I think that it's kind of it's a difficult spot for patients, and I mean for me the most important thing is I want my patients to have access. I think that there are obviously some fraudulent compounding pharmacies, and there are means for these products to be potentially counterfeited, and I think that's obviously a huge issue. And I do think that sometimes when these compounded products are shipped out, if patients aren't careful, they could end up giving themselves the wrong dose, and there have been several reports of patients potentially overdosing on these types of medications because the compounded product was mislabeled, or they gave more than was potentially listed, or they didn't titrate appropriately, and so it is definitely more difficult and requires much more fine-tuning than giving the patient a pen directly from the manufacturer. And I would 100% support providers using the FDA-approved products in general. And my hope is that, and I think that this avenue will likely close for compounding, but my hope would be that as more patients obtain coverage for these classes of drugs and the price decreases on these classes of drugs, that there really won't be a need for compounding. That need, I think, is mostly being filled right now due to medication cost and coverage, unfortunately.
Yeah, yeah. Well, so what would we recommend for people who are thinking about these medications and wondering, would this be right for them?
Yeah, I mean, I think that we kind of went through our little comparison of different treatment approaches earlier. I think that we're aware that there's several drugs on the market now at a variety of different price points. There are agents that are oral, there are agents that are injectable, so a little bit it depends on that. There's that price point difference, I think, is important in whether or not you have coverage for these classes of drugs, as well as your finances will kind of partially dictate what treatment is chosen as well. As providers, we want our patients to be on the agent that makes the most sense and has the most clinical benefit. And I think that varies from person to person and should be a conversation that patients have with their physician. But I think that we know that these newer drugs and that there's new things on the market that may potentially be appropriate, especially if you have concurrent disease states that we have spoken about earlier, like a previous heart attack or stroke, like sleep apnea, like fatty liver. Those patients, I think, should be heavily encouraged to look into some of the newer products. And then patients may benefit from surgery, and we still know that that's the most effective option. We know that Medicare Part A covers that bariatric surgery fairly well for BMIs 35 or higher, or 30 or higher with certain medical conditions. And so I think that it should be a conversation that patients have with their providers, but know that there's a wide variety of choices at this point, and I think that patients can go in knowing that there's options and that there's treatment choices, and that they may vary by route of administration and by cost and by potential benefit in certain disease states, but there are options, really a lot of options for the first time ever.
Yeah, that's the message I want people to hear too. Obesity really is treatable. There's lots of ways to approach this. Sometimes you have opportunities to take advantage of those. Sometimes you don't have the insurance coverage and can't afford the cash price. And in that case, it's really my mission right now through our nonprofit to address those issues in the political policy, in the payer policy, trying to figure out a way to get coverage to the people who really need it the most. So if you happen to be out there and wondering if treatment is right for you, wondering if you should consider that, at least start talking to your doctor about it, and use some of these tools to check your insurance coverage. See if your insurance covers them, see how much they would cost you. Go through the step-by-step layout that we've set for you here, and get some information, see where you stand, and explore all these resources. I think the benefits for treatment for some people are huge, and for others, you may not have medical conditions related to obesity, but we still feel like treatment is reasonable for people who are stuck without medications after all that they can do.
Yeah, I think as healthcare providers, we got into medicine in the first place knowing we wanted to do what's best by our patients. And it's nice to be able to offer new things for the treatment of obesity that haven't been around, and to really see, I mean, anecdotally, my patients, I've seen a large difference, and I have many patients who've lost a great deal of weight, and they feel like a different person. And it's truly wonderful to be able to offer something like that for the first time in a long time, and the results are a big deal. And I mean, it's noticeable even looking at these patients, but also knowing that their risk of having another heart attack or another stroke has gone down tremendously. I feel like it's truly a wonderful time to be practicing.
Totally agree. Totally agree. Okay, we've talked about cost, access, coverage. Now, let's say that your doctor ends up prescribing the medication, What happens after the prescription's sent in? What's the next step?
Yeah, so there's something in the insurance world that we call a prior authorization. And generally for high-cost drugs, such as the new medications for weight loss, your insurance wants verification that there is a clinical need and a clinical benefit for you to be on this medication. And so your insurance company will have your physician fill out paperwork, basically, to verify that you're a candidate for that class of drugs. And so basically your healthcare provider will submit this paperwork showing, yes, you have obesity, and yes, you have sleep apnea, and here's your sleep study. And that's basically how insurance determines which patients are candidates for specific diseases, for specific drugs. And so I think it's important to note that every insurance company has different requirements. And it varies by plan, it varies by insurer, and so there's a great deal of caveats amongst this. But typically, your healthcare provider will submit paperwork, and then within a week or so, your insurance company will respond with whether or not you have coverage. And if you're approved for coverage, then notification is sent to your pharmacy to let them know that they can rerun that prescription, that it's approved, and then it will go through for whatever your typical copay would be.
Yeah, so after it's approved, you might get a surprise. You might find out that the copay is high. You might find out it's only $20. That'd be cool. And sometimes that happens too. And then you have your deductible to deal with. Explain how that works.
So typically, at the beginning of the year, many patients have a deductible to pay down. Medicare has a deductible to pay down. It varies between commercial plans, but that deductible may be. Some patients have high deductible plans that they've selected. Some people have low deductible plans. But basically what a deductible is prior to your insurance paying for usually higher tier drugs. Higher tier drugs means typically more expensive medications. They will require you to pay a certain amount of your own money to pay that down prior to coverage, where you'll get into your typical copays. And so for Medicare, that's typically about $500. For commercial plans, it varies widely. I have patients with $500 deductibles. I have patients with $5,000 deductibles. But you may have to pay that down before you are able to obtain coverage for these drugs. Unfortunately, the good news is for commercial patients, you are able to use those copay cards, which help bring that cost down as well. Unfortunately, Medicare patients are not eligible to use those copay cards, and so for that Medicare deductible, you generally will have to pay that down prior to going down to a typical drug copay of $45 or whatever that may be. Now, Medicare does have something new this year called the Medicare Savings Program, and so patients are able to enroll, and I think this is an important caveat. Next year, Medicare will have a $2,100 max out-of-pocket for prescription drugs. You are able to split that cost over 12 months, and so the nice thing is then all of your covered medications would roll up into that. So you'd take $2,100, divide that by 12 months, and that's how much you would pay your insurance company. And then your drugs at the pharmacy, your covered meds at the pharmacy would be fully covered. So it would be roughly $200 a month that you would pay the insurance, and then you wouldn't have to worry about paying down that deductible or anything like that. The nice thing is, for many years, Medicare did have a coverage gap as well, but very recently that went away. And so previously, patients would have to pay their deductible, then they would get general coverage, and then they would go into the coverage gap where they would end up having to pay 20% of the cost of their drugs. But thank goodness Medicare has gotten rid of that the last few years, and so it's taken away a significant strain on patients for sure.
Yeah, that was a big complaint point for sure. On those copay cards for everybody, take a look at the fine print. There's a maximum savings allowance, and they're all different. So just check that and make sure you see that. Sometimes it's $150 a month. Sometimes it's $250 a month, but it'll be in the fine print on those cards and on their medication websites as well if you don't have the actual physical card.
Yep. And once again, only available for commercially insured patients. So if you have Medicaid or if you have Medicare, or really any government coverage, if you're on TRICARE or something like that, if you have government-funded insurance, you can't use copay cards, unfortunately.
Well, Casey, there's a lot in here with medication coverage, how to choose the right medication, how to choose whether to use a medication at all in the first place. and then cost, coverage, all that stuff. Thanks for giving us a great rundown on this. You've really been my go-to over the past year or so with all these questions, so it's been awesome to have your support on the back end as well. But for people who are confused about the process, hopefully this lightens things up a little bit and clarifies things, the process a little bit. Use these tools that we've made. You can click on the links and download the sheet, and then hopefully some of those graphs and tables that we shared could be helpful. I know it's super technical as far as like which medication to choose and what the characteristics of each medication are. But remember, if you feel like you want to get treatment, you feel like you need to get treatment, yeah, don't hesitate to ask. Casey, any messages you want to send to people who might be considering this pathway that you want to just lay out there for us?
I just think it's important to note that treatment is an option, and so if you've tried diet and exercise and you're feeling stuck, you may be a candidate for these types of medications, and it's worthwhile to have that conversation with your provider. I think for many years, unfortunately, that we didn't have a lot of options, and now we do have options, and I think coverage is increasing over time here. And so I think it's important to talk to your provider about lifestyle programs, medications, potential bariatric surgery. There are many options, and I encourage patients to look further into that and to check out the tools that we talked about today on the podcast to see if they may be a candidate for something like this and discuss it with their provider.
Yeah, thanks. Well, if you guys want to hear more about what it's like to be on a GLP-1 medication, like Wegovy, Zepbound, one of those injectables, we're going to be doing a podcast here in a couple weeks with Lauren Scott, who I talked to a month or two ago, one of my patients who's gone through this process and still going through the process. She has some really great insights into what it's like to be on these medications. Also, if you would like to follow the Arizona Obesity Organization and follow SB1711 and what that's doing, you could follow us on our Arizona Obesity Organization social media. And then, Casey, you're over at Optum Clinics, so people can get care there. I'm over at Forte Wellbeing, so anybody who needs medical care, wants to touch base with us, get in touch with us at our medical practice. We'd love to have anybody in Arizona who needs to get care. All right, well, remember everybody, obesity is treatable. Don't forget it, and we'll see you next time.
Thank you for having me, Doug.
Yeah, thanks, Casey.